Hello. I was asked to give this talk on medical record reviews because of a significant amount of experience doing them in the past. I've done medical records reviews for insurers, attorneys, and companies located in places as far away as South Dakota, North Dakota, Wyoming, Idaho, and of course here in Montana. I hope to give you some of a basic idea of why you might want to use a record review and reasons why you might want to defer a medical records review to a more in-person evaluation of a person. I don't have any financial disclosures to make at this time. So why would one request a medical records review? The most common reason is to obtain a rapid answer to a simple question. Some of these questions are pretty obvious. One is to determine if a recommended treatment is endorsed by the Montana Utilization and Treatment Guidelines. Sometimes the treatment recommendation is actually in the Utilization and Treatment Guidelines, but the requesting party is unaware of that. Other times the treatment is not endorsed by the Utilization and Treatment Guidelines, but is endorsed in the evidence-based medical literature. So sometimes I will actually look up the literature when I don't find it in the UNT guidelines and provide evidence for why the treatment should either be allowed or not allowed. Another reason to get a medical records review is to determine if further treatment is necessary. Sometimes treatment will go on for a long time. This typically is the case with modalities such as physical therapy or chiropractic care. Again, I personally use the Montana Utilization and Treatment Guidelines to determine the treatment parameters for a particular treatment, such as physical therapy or chiropractic treatment. Another reason to ask for a medical records review is to obtain an impairment rating. There are a number of conditions that require impairment ratings but don't require physical examination. One of those is hearing loss. That impairment rating is completely based on an audiogram. Any kind of pulmonary injury is completely based on actually on their medication usage and on pulmonary function or maximum oxygen consumption rates. And these are things that are measured in a pulmonary function laboratory, and all the person providing the impairment rating needs is the result of that evaluation. They don't need to see the person. Obviously, the other one that can be done without an a physical examination is COVID-19. I've been doing a number of impairment ratings for folks with work-related COVID-19, and those often are based solely on medical records review and or telephonic visit with the person, supplemented by a review of their medical records. Finally, a reason to get a medical records review is if the injured worker no longer resides in Montana. Typically, when this occurs, that medical records review is supplemented with a telephonic visit. The remainder of this talk is really going to focus on the limitations of a medical records review. There are a significant number of limitations that you need to be aware of so that you can use this type of evaluation wisely. One of the limitations of a medical records review is the inability of the reviewer to obtain a history from the injured worker. This is really important when you have very poor quality medical records to rely upon. It's also really important when you're being asked to perform something such as an occupational disease evaluation, where you really need to talk with that person. One of the limitations, and this kind of goes into this thing about not being able to obtain a history, is that you can't ask questions about their past. This is particularly frustrating when one of the questions the requesting party is asking is about perhaps an aggravation of a pre-existing condition. There's no way to know that if it isn't in the medical records except by asking the person. So this feeds into the next bullet point, which is that it's very difficult with simply a medical records review to address exacerbations and aggravations if that information isn't in the medical records. The limitation here is that the medical records that we typically receive begin at the date of injury. It's very rare, in fact, that I have medical records that predate the date of injury. And finally, one of the limitations, we're going to go into this in a lot of detail, is the quality of the medical records, and they vary. It varies by the medical knowledge of the condition of the person actually documenting those records. It also varies by the medical specialty. Obviously, a family practitioner evaluating someone for a radiculopathy is going to have a very different medical note compared to a neurologist or a neurosurgeon. There are a number of other limitations of medical records review. I find it often impossible to address issues of work restrictions and return to work solely based on a review of the medical records. Sometimes this is because the medical record quality is very poor. Sometimes it's because the person's injury or occupational disease is very complex. Along with work restrictions and return to work goes job analyses. Without high quality records, without a functional capacity evaluation, it's very difficult to address those types of issues in terms of employability. Also, and finally, maximum medical improvement. I really personally don't feel comfortable placing someone at maximum medical improvement solely based on a medical records review. I like to be able to eyeball the person, to get a history from the person, and do a physical examination on the person. Again, all of these things can be done with a medical records review, but they really require high quality medical records. Contrary to popular belief, there are only a limited number of impairment ratings that can actually be performed using just medical records. Virtually all the impairment ratings in the AMA guides require some form of physical examination. There are exceptions, as I mentioned earlier. Hearing loss is something that is based solely on an audiogram. Lung injuries rely solely on pulmonary function tests, the VO2 max, and that's your maximum oxygen consumption, basically a measure of your lungs' efficiency at gas exchange and your heart's efficiency at pumping oxygen to your body. And then also medication usage in association with whatever the pulmonary disease is. Usually medication usage is most important when a person suffers from asthma. But as I said earlier, most impairment ratings rely on the history for the functional history adjustment and a physical examination for the physical examination adjustment. There are a number of impairment ratings that can be done without performing a functional history adjustment and a physical examination adjustment, but those then rely on things like range of motion. Obviously, range of motion is something that has to be done in person. So I've already mentioned low quality medical records. I think it's really important for everyone to understand what that means because this is something that you can judge for yourself just by reading through them. Traditionally, medical records are broken into 4 parts. The old SOAP note, it's an acronym actually, and SOAP means subjective, which includes the subjective complaints of the person. Objective, which includes their physical examination and any diagnostic studies. Assessment, which is what you think is wrong with the person, or the diagnosis. And then plan, which is what you're going to do about it. It may be additional treatment, it may be additional diagnostics. So that's the old SOAP note. But in more technical terms, we break a medical note into the history of present illness, and objective again, which is the physical examination and diagnostic studies. And under history of present illness, there are a number of areas that you as a requesting party can judge for yourself if the medical record is high quality or low quality. So things that I find in medical notes all the time are they'll describe the person's symptoms and they won't give a description of the injury. They only state that a body part has been painful or dysfunctional, and they rely on the injured worker's statement that it was caused by work. Oftentimes I will see the description of the injury documented incorrectly. It will either be completely wrong. I have actually seen descriptions of a shoulder injury and it's about someone's knee. So they were dictating on one person and maybe they were distracted and then came back to it and thought they were working on someone else when they started dictating. I also see not only wrong body part, but wrong side. It's a right shoulder injury, but they're talking about the left shoulder. Or they'll switch back and forth between right and left. You don't know what they're talking about. They'll describe job duties as being repetitive or strenuous, but they won't give you anything more than just that. And this is really difficult when you're trying to determine if an occupational disease occupational disease exists. In the medical literature, repetitive actually has a definition, and the one that I like that's I think most useful is when they describe it as cycle time. A cycle time of less than 30 seconds is considered repetitive. So if you are making widgets or moving widgets or packaging widgets, and each widget takes you less than 30 seconds to do, and you do this 8 hours a day, then we can say, yes, you have a highly repetitive job. Often we'll have images of the workstation, a crash, or a surveillance video provided, but in medical record reviews, that is often not the case. A person's workstation will be called dysfunctional or inappropriate, but there will be no description of the workstation. The person evaluating the injured worker won't obtain that history from the person. If there is a motor vehicle collision, they will just say there was a motor vehicle collision, and they'll rely on the injured worker for the velocity of the vehicles involved, and basically then we'll only say, whether an airbag was deployed or not, and whether or not the person was able to extract themselves from the vehicle. Sometimes they'll address whether the person lost consciousness in the collision, but that's it. And so you have to go from that. One of the things that you can do for anyone that is going to perform a medical records review for you is to provide them with a first report of injury. It's really important to have that first report of injury so that the reviewer can compare it to the medical records description of the injury or the occupational disease. I can't tell you how often they are not the same. The other thing that is really important and often not included in a medical records review is a job description or any other kind of completed job analysis. This is really helpful when one is being asked to review medical records in order to determine if somebody suffers from an occupational disease. I see this most often in folks that are asking about the presence of things like carpal tunnel syndrome. Something that honestly drives me crazy is when providers use electronic medical records and basically repopulate the history and sometimes the physical examination and assessment with the previous record. And so you will literally get an identical record with the only thing changed being the date. I have literally recently seen this on 7 consecutive visits. The only thing changed was the date, and everything else, physical examination, history, everything was identical. And it was 7 times, and it was every 2 weeks, so we're talking, well, you can do the math. I think that's inappropriate. And it's not useful. It's very, very low quality medical records. It's very hard to determine what's going on with that kind of a record. Another thing that's really problematic for us doing medical records reviews is when the provider uses voice-activated software and either is mumbling or is speaking too quickly for the software, and most importantly, after it has translated his or her speech to text, it comes out as word salad. And they don't go back afterward and review it and correct the word salad. So it sometimes will be a whole sentence that is kind of important, but it's just words strung together, and there are many times not even medical words. I've literally seen whole paragraphs of word salad, and all you can do is just go, well, can't use that. Another problem with low-quality medical records is what I already talked about, which is no records that predate the current condition. It's really important if you can get your hands on those records to do so. I have had individuals who have conditions, even things that they're claiming now to be work-related in the past, and there's a slight mention of it in a medical record that I obtain, but no other mention of it. And since I am unable to talk to the person and find out when they had the carpal tunnel syndrome or the wrist pain, or when they were diagnosed with rheumatoid arthritis at some point in the past, you can't find that out. And so records that predate the current condition are really, really important to put the current condition into context. So we've talked about the S, or subjective part of the SOAP note, the history, present illness portion of the record. Now let's talk about the physical examination, or the O, objective part of the note. Things that constitute, in my mind, low-quality medical records are things that I find very important and very helpful. One of the things that I find less and less in medical records is an actual height and weight. I have seen people going to their treating provider for years without ever having their height or their weight or their blood pressure or even their temperature measured. And obviously for some things it's kind of important. So with knee pain, if you're 5'6" and weigh 150 pounds, well, that's okay, you've got knee pain. But if you're 5'6" and weigh 350 pounds, well, maybe it isn't your work that's causing that knee pain. But without those the vital signs, if you will, I can't make that determination. The other thing that I find most frustrating is a poor description of the physical examination. So they will describe tenderness, or they will describe pain in the shoulder, but they won't tell you where they found the pain. They won't tell you what they did to provoke the pain. They just say shoulder tender. What's even worse is when you think you're addressing a right shoulder, and they say left shoulder tender, right shoulder benign. What does that mean anyway? Another thing that makes quality of records low is when the provider examines every part of the body except the part that's actually the subject of the claim. So the person has a back injury, they'll do the head, eye, ears, nose, and throat. They'll listen to their heart, they'll listen to their breathing, they'll examine their abdomen, and they won't examine their back. And then they'll say they have a radiculopathy. I don't know how that happens, but it happens often. Physical examination is something a little bit more difficult for a requesting party to look at, to read through, and determine if what's documented is of high quality or low quality. Some of the tests that I'm mentioning in this slide are things that probably would be difficult for one of you to evaluate unless you had a medical background. Waddell's tests were designed by an orthopedic spine surgeon in Scotland to determine if a person's back pain and radicular pain were being caused by an organic condition. They were used to supplement other forms of physical examination and imaging studies before actually performing surgery on the person. They were designed to be used on low back conditions. Waddell's tests aren't designed to be used on any other part of the body. Although that is the case, I've seen Waddell's tests applied to neck injuries, shoulder injuries, and knee injuries. It's not appropriate and it's inaccurate. I also see tests incorrectly interpreted. A straight leg raise test is used to determine if a person has significant radicular pain. Radicular pain means pain that goes down the leg past the knee, and to have a strongly positive test, you're looking for pain that goes into the calf and into the foot. Often I will see straight leg raise tests being interpreted as positive, and yet when details are given, and often they are not, they will state that they're positive for back pain. Many people will have back pain if their legs are raised to 80 or 90 degrees, but that doesn't prove the presence of any form of radiculopathy. Another thing that is difficult to interpret is when symptoms are, again, documented in the section of the report that is for the physical examination. That information should be in the history of present illness section of the report. Moving on with the objective portion of a medical record. In this case, we've already gone through physical examination, and now we're going to talk about diagnostic studies. A key problem is when there are no diagnostic studies in the records. They mention them. Oh, they're coming back for their review of their shoulder MRI, but the shoulder MRI record isn't in the set that's submitted to the medical record reviewer. Or the person is assumed to have a rotator cuff tear, but there's never been a shoulder MRI done, and either the provider thinks they need to go to see an orthopedic surgeon, or the provider is an orthopedic surgeon and thinks they need surgery without having actually done any form of imaging studies. Another issue is when diagnostics are inappropriately or inaccurately interpreted. I see this often where I have the MR scan in my possession so I can look at the report, and I see that the radiologist is calling this a disc bulge, and there's no spinal canal or a foraminal stenosis, but the person who actually ordered that diagnostic interprets the disc bulge as a disc herniation and immediately wants to send the person to a surgeon. Another is when diagnostics to exclude other sources of the person's complaints aren't done at all. This is why I always like to get diagnostic studies. Again, this is kind of part of my training. I see this very often with carpal tunnel syndrome, where the person is assumed to have carpal tunnel syndrome that's related to their work because their work is, quote, repetitive, end quote. But again, there's no documentation of just how repetitive and what they're doing that's so repetitive. But then no other diagnostics are done to determine if there are other sources of their carpal tunnel syndrome. There are a number of other sources of carpal tunnel syndrome. Pregnancy is one, obesity is one, low thyroid function is one, diabetes is one, rheumatoid arthritis is one. A history of wrist fracture is another source of carpal tunnel syndrome. And none of these things are done to make sure that the carpal tunnel syndrome is work-related. So in this regard, when you are asking a provider to do a medical records review, when there are diagnostic study reports in the record set you plan to send, you should find out from your record review provider if they want the actual images or not. As a part of my training, I was trained to never, ever, ever review MRIs and radiographs and ultrasounds and everything like that. The faculty in my residency were adamant that that was the job of radiologists and cardiologists and all these other folks that spend all of their time looking at those kinds of things. And my efforts were better spent doing other things. And so I was not trained to look at MRIs, and I don't look at MRIs. I figure the radiologist spent 5 years learning how to do that. They probably do it better than I do. So by now, it should be fairly clear that there are perils and pitfalls to medical records reviews. I am certainly very cautious when agreeing to perform a record review because there is a wide range in the quality of the records I'm asked to review. Because there's such a wide range in the quality of the records, I really need to know what the requesting party wants out of those records from me. It depends on what the goal of the records review is, in my mind, as to whether those records are adequate to the task. So I always ask for a letter from the requesting party that details what they want to know. So that might be something simple like appropriateness of treatment, or they had hearing loss, we just need an impairment rating, here's the new audiogram, or something of that nature. But when we start getting into things like we need to know if the repetitive lifting of boxes of toothbrushes from a pallet and stocking them on shelves caused them to have a C5-6 disc herniation and need a single level fusion in their neck. That's an entirely different kettle of fish in my mind. And it will really depend on the quality of those medical records as to whether that question can be answered simply by a medical records review. Sometimes a medical records review alone can't answer questions. Sometimes it can be done if you allow the reviewer to obtain information from the person telephonically. So a phone call just to ask certain questions. When I do these, I often ask about things like, how long have you worked there, and what are your specific job tasks, and what happened on that day, how many boxes of toothbrushes were on that pallet, and how long, over what period of time were you, doing that job? Did you trip on the pallet? Did something happen? All those details really help to fill out the picture and then make that medical records review more valid and thereby more useful to the requesting party. What I like to see in a letter may be different from what other record reviewers might want to see. Personally, I like to know, particularly when there are multiple conditions in question, what conditions you as the requesting party have actually accepted. It's often not obvious in the records, particularly in the older injured worker where they might have a number of different health conditions. It may not be clear what is actually been accepted. It may also not be clear what is being contested. I have had it happen where a record review that I thought was about a person's musculoskeletal system was actually about another organ system that the person thought was related to their claim. And a good example of that is the person that has a shoulder or a knee condition and develops gastritis, inflammation of the stomach, and they're claiming that it's because of all the anti-inflammatories that they were taking because of the shoulder or the knee condition. So, it's helpful to know that that's what you're actually asking about. So just saying what are the accepted conditions or what is work related, that doesn't help me if I don't know that what is also involved in this is, a stomach condition. The letter should also include specific issues to address. Aggravation, maximum medical improvement, restrictions, treatment recommendations, all of those things. If you want to know them, you need to ask them. If you don't ask them, you won't get those questions answered. One of the things that is very frustrating for a record reviewer is when a requesting party asks about objective findings. What are the objective findings that support this objective complaint? And you're doing a medical records review. If there are high quality medical records, let's say a person has been treated by a neurosurgeon who's really done a good job of physical examination and describes all the neurologic findings that support that they have a radiculopathy, then it's a cakewalk. But if you have someone who doesn't have that skill level or who doesn't use the skill level they have, and they just very tersely say, yes, they have radicular symptoms in the L5 distribution, that doesn't, okay, sure, okay, you've got radicular symptoms. What are those symptoms, and what do you have that objective, that again, that symptoms, that's not objective findings, but also what are the other things that make you believe that this is a radiculopathy? So if you ask about objective findings, they need to be in those medical records, otherwise that question can't be addressed. Finally, one of the things that I find most difficult to answer is that about cost of care and also about future care. Cost of care is outside of my sandbox. I don't know the first thing about what things cost in medicine, and so I really can't address that. That's something that varies from facility to facility, so you just need to find out from that facility what they charge. And then if you also have questions about future care, if the diagnosis is obvious, if it really does seem to be work-related, let's say the person has been a pipe fitter for the last 20 years and they've used tools weighing 10 to 15 pounds repetitively, cycle time less than 30 seconds, 8 hours a day for the last 20 years. And they've got swollen wrists, and they've got numbness and tingling in their fingers, and they've been awakening from sleep at night with their hands numb and burning and painful, and they have positive electrodiagnostic studies, then I'm going to call that a work-related carpal tunnel syndrome. Particularly if they also document the person isn't a diabetic and they have normal thyroid function, then it's kind of a slam dunk. Yeah, okay, you got carpal tunnel syndrome. And when I have all of that data, then I can talk about future care. Yeah, well, they need maybe first try an injection, try occupational therapy for tendon gliding, see if that helps, see if an injection helps, you know, and all the different things that you would do along the way before you actually do a carpal tunnel release. So in those cases, yeah, you can talk about future care, but often you can't because you don't have all of that information in medical records review. In those cases, you really need an in-person evaluation. And now I'm going to stop talking and hand the podium over to Leah Morrow, who will talk to you about administrative details associated with a records review.